ASOKA Services welcomes you to yet another session. We will again be discussing health policy and trying to see how we measure implementation of this policy. So we will be changing this policy to data. The policy we will discuss today is the adherence guideline. Just as a disclaimer, this is not meant to replace any training that the department might have arranged for any clinicians. It is just here to give an overview of what the guideline has, and so as to provide understanding for everyone who has to interact with implementation of this data. For example, your non-clinicians, your data capturers, or even your NGOs. So let's move on. The background to this guideline is the fact that our country, South Africa, has the largest ART program globally due to the numbers of HIV positive people that we have. We also have a lot of people in our country with more than one disease, HIV, TB, or even other conditions, other illnesses. And all of these together, they have prolonged the time or the lifespan of the community within South Africa. This on its own has then made it or highlighted the need to have a strategy that would deal with just adherence to treatment. The National Adherence Guideline then aims to close this gap. It makes sure that everyone has access to services, healthcare services, and the interventions that they might need so that we can improve health outcomes within the country. This is done by making sure that everyone with chronic disease is linked to care, is retained in care, and is supported throughout their adherence on treatment. The standard operating procedure that you see on your left is based or is a subset or is a way of implementing the adherence guideline. It makes sure that patients are looked after or they are provided different care models within the healthcare system. It focuses on interventions like your integrated care for patients with chronic disease. That is, they would get everything that they need in one roof instead of going from one place to the next. It looks into standardizing education and counseling sessions that patients are provided. This starts from your patients that needs to start on treatment. We fast track them on treatment by providing counseling so that they understand what they are getting into, making sure that those that are on treatment already understand their treatment pathway and adhere to their treatment. The children and your adolescent, we help them through, this program also helps them through disclosure and accepting their illnesses. That will be education and counseling sessions. Then we also have what we call the DMOC, differentiated model of care. This is for stable patients that needs to collect medication now and then. Those people that are on chronic medication already, but just need to go to the clinic just to pick up medication. And those that needs to be switched from one drug to the next. It also deals with tracing or re-engaging those patients that are on chronic medication but might have fallen off their wagon at some point. So it provides a way for us to go and look for these patients, trace them back to care, and when they are back and when they have come back to the clinic, then give us a guide as to how to make sure that they stay on treatment with all the adherence counseling that they get. This diagram summarizes everything that the National Adherence Guideline or the SOP aims to do. Basically, if you look on the top part, it will talk about, if you look at this part, it will tell you from case finding, making sure that we find patients very fast before they complicate in their illness. So we diagnose them early so that if they need treatment, we start them on treatment early. Once started on treatment, we make sure that we maintain them on treatment, keeping them adhering so that they can have a lifelong, a productive life. Once they're on treatment after 6 months, in some of the cases, in this case HIV, or even some of the chronic medication, then we can decant them or give them an option to just come and collect the medication. All of these activities are done based on the counseling sessions that the patient get as the need arises, and tracing them back to care, as we have said, tracing them back when we have lost them, and integrating them back again to care. So this video will focus on that red part, which is the repeat prescription collection. This part, we will discuss all of these things which are applicable to patients that are on chronic medication. They are stable. They just need to come to the clinic to pick up medication only. The repeat prescription collection strategy, which is your RPS, has two interventions in it. It has the drug switch that we talked about, as well as the repeat script collection. The RPS is the one that you see on your left. We will discuss in detail the repeat script collection RPS as well as the drug switch. Who is eligible for RPS? You can see we have adults that are eligible. Obviously, they need to be above 18 years, having to be on treatment for at least 6 months, and they are stable on that treatment, being HIV, diabetic, or hypertension, in line with the normal range of that chronic disease. The patient needs to want to come, to be enrolled for this RPS, and they must not be having any other medical condition that needs them to come to the facility more often. For pregnant women or those after birth, we do not, the system or the strategy does not accommodate pregnant women. Even if the woman was on ART before, once they get pregnant, they have to be managed within the bank, side of health, for everything, for ART and even for their antenatal care. So they are not eligible to enroll. And a mother who's not in the same care as the baby, as the infant, that does not need to go and visit the facility together with their child, can be enrolled on RPS, provided that they are seen at the clinic every 6 months, and viral loads are taken until they can stop breastfeeding. Children and adolescents are also eligible. From the age of 5 to 18 years, below 18, they can be enrolled. They must be on treatment for 6 months and in the same regimen at least for 3 months. So if a child has changed the regimen in the past 3 months, we cannot enroll them on this strategy, even if they've been on the treatment for 6 months. The caregivers must have been cancelled on disclosure for the child. If not, then this service will be provided. If the child is less than 12 years, then there must be a caregiver that opts to get the child registered on RPS, or a child above 12 years can register on their own. There must not be any medical illness or mental, condition that the child has. And if there's any malnutrition, also the child is not eligible to be registered onto this care. Let us now then look at the different types of this care. But one thing to note is the clinician still has to confirm, even if both the adult, the child, and the pregnant woman meets the criteria of eligibility, a clinician has a final say as to the eligibility of this patient. Let's discuss in detail then the facility pickup point, which is also in describing it. It's when a patient has to come to the facility to pick up their medication. This patient does not have to pick up a file, having their their vitals done, or even see a clinician. These patients will go in a fast lane to a pharmacy, or they can be seen in a designated room or area in the facility, or somewhere after hours in the clinic, or even in your mobile or outreach point. One thing to take note of, the treatment of these patients does not have to come from one source. The patient's medication can be prepacked by the facility, by central dispensing units, or by the centralized chronic medicine dispensing and distribution units, which is your CCMDD. So those patients, as long as they can come within the facility in an area where they can pick up the medication, that's what defines a facility pickup point. The guiding principle for this strategy is that the patient must opt in, obviously, to be enrolled or not. And this enrollment or deregistration must be written by the clinician on the clinical notes as such, and it must be captured on tier.net for HIV patients or any other paper register for the other chronic illnesses. As we have said, the facility pickup point has a dedicated area in the facility. So there must be a dedicated area in the facility to provide this service in, and the facility can only have one facility pickup point in the facility. It cannot be more than one. This pickup point cannot interfere or have a negative impact on the general services that are being rendered in the facility. So, for example, if it is supposed to be in the consulting room where they pick up, then it is interfering. That consulting room could have been used for something else. If they are in the same queue, for example, with other patients, then it's not the ideal place to have this facility pickup point. The medication must at least be ready a day before. They must be prepacked. There's no need. If, for example, the patient has come for yearly bloods or, examination that must be done. For the bloods, you do not have to wait for the results to come back for us to renew the script. Once the patient is there and they are collecting the medication or they are renewing the script, you collect the blood, you renew the script, and you submit the script. You do not have to wait for the blood results to come back. Once the blood results are back and they are not within the normal range, then the patient can be deregistered and the patient be called back to pick up the medication in the facility. One thing to note is that documentation is very key in all of these, strategies, because without documentation, we will not know what happened to the facility. Just as I repeat, there's always, in one facility, there can only be one facility pickup point. So it cannot be a facility pickup point if you are having more than one modality. There can only be one facility pickup point. The Adherence Club is another strategy. As a description, it needs a group of people from the same area, like closer to the clinic perhaps, or the same population group like your teenagers, or it could be family members together. That makes a group. And the group has to be between 10 to 30 individuals together. This group has to meet together and collect the medication at the same time. If they are coming one by one, then it is not an adherence club. The adherence club, they will come together, sit in a group, have discussion, engage, and then take medication together, and they would leave. That means if it is not a group, we are picking up one by one, it then is not an adherence club. It might be a facility pickup or an external pickup, but it's definitely not an adherence club. The same as the facility pickup, any of those three, the facility, the CDU, or the CCMDD, can pack medication for this club. The guiding principle, as we have said, it has to be a group of people. This can be established within the facility or in a community somewhere. Registration and deregistration must be reflecting as such in the clinical notes, and it must be captured as well on tier.net as such. The medication to be picked up must be at least be in the facility a day before, like with the other one. Like with the facility one also, the script submission does not need to wait for the results of the patient, but the patient can always be recalled back if the results are abnormal and deregistered on the system. And documentation is still key. Just to remember that if it's picking up as a group, then it is an adherence club. But if we are not picking up and meeting as a group, then it is not an adherence club. The external pickup point is defined as when people go, it's a place where people go and collect outside the facility. It can be from an automated system, or, a building, but it's outside the facility. The external pickup point can be a pharmacy, it can be a designated community venue, or it could be a post box or any of the automated systems. But one thing to take note is that for an external pickup point to be an external pickup point, the medication is only packed by CCMDD. If it is packed by the facility or the CDU, then it cannot be an external pickup point. It could have been a facility pickup point or an adherence club. For an external pickup point, medication needs to come from CCMDD. The guiding principles for external pickup point is that all external pickup point locations are outside, and the patient can choose what is most suitable for them. A patient might be staying in Albertine, but can pick up in Johannesburg because that's what is convenient for them, maybe due to the reasons of work or any of those things. This must also be reflecting in the clinical notes and clear so that the capturer can capture correctly on TA and put the patient in the correct, modality. The medication obviously will also have to be at the pickup point at least a day before. And the same as the other one, the results that we are waiting for do not have to hamper the submission of a new script. If the results come and they're abnormal, we can recall the patient back. Documentation is still key. Just remember, the pick-up points are organized by National Department of Health, then that is an external pick-up point. If a patient is not something, if the pick-up point is not what we organized as a clinic, but it's something that already comes organized from the National Department of Health, then that patient is picking up from the external pick-up point. We also saw switching of ART first-line regimen as one of the, of the care that we give. This is where a patient that has been on ART, has been on RPC for some time, is actually now eligible to be switched for the new first-line drug that we have in our system. So this SOP actually guides one as to how to go about it. But one of the things to take note is if the patient is eligible and is willing to be switched from whatever they are using to the new first-line regimen, they do not have to be deregistered from any of the RPCs. We must just make sure that if they are then switched from the old one to this new, that the script is also updated as such. Remember, for us to be able to measure the implementation of any of these policies, we need to keep record as well as to report. This is the same for the DMOCs as well, which is the clinician need to write clearly on the stationery, as we have said. Whatever is on the stationery needs to be transferred correctly onto TA according to what the RPC that the patient might have, chosen. Then, as if the clinical notes or stationery is written clearly, then the capturer has the duty to capture it correctly on that. And we report this in line with the data elements as well. Remember when we did the data collection tools and the tick registers, there were some data elements. We also have an electronic register that deals with CCMDD, which is called SYNC. These we need to look into because it's the only way we will be able to report and measure the implementation of the NAS guideline. These will be covered in separate videos. Thank you for watching this one. Please subscribe on the button that you see at the bottom on your right. Click on that button to subscribe. Then you will get a notification when new videos are done. Thank you for watching this video. Goodbye for now.